Hello and welcome to OffBlueMedical. Today we're going to be talking about 10 more quick notes for the USMLE. So the first one is about torch infections, and torch infections are many and you have to know all the details of these for step 1, step 2 and step 3. But quick differentiation tips is that you have to know for toxoplasmosis you're going to see hydrocephalus, generalized intracranial calcifications and chorioretinitis. For cytomegalovirus, you're going to see microcephaly and periventricular calcifications. So you have to know that in toxoplasmosis you saw generalized calcifications, while in CMV you're going to see periventricular calcifications. And you're also going to see petechia and sensorineural hearing loss. For rubella, you're also going to see hearing loss, deafness, also cataracts, and congenital heart defects. So for the USMLE, two things you have to think of when you see deafness. First one is rubella, and second one is going to be CMV. The other one is syphilis. You can see osteochondritis, a disco-emitting skin rash involving the palms and soles, and snuffles, which is mucopurulent rhinitis. In myotonic dystrophy, and you have to know that myotonic dystrophy is an autosomal dominant condition. It causes impaired muscle relaxation, and for the USMLE, the tip is they say an abnormally long handshake in the question, or that the patient doesn't let the hand go, or they cannot open a jar, or after they open a jar, they cannot release their hand. This is going to be myotonic dystrophy, and you have to know that there are other associations with this, also cataracts, balding, gonadal atrophy, or testicular atrophy. In inflammatory myopathies, you have to differentiate between polymyalgia rheumatica and polymyositis and dermatomyositis. So for polymyalgia rheumatica, this condition typically affects patients over the age of 50, typically females. This is also associated with temporal arteritis, and it presents with stiffness that is greater than pain in the shoulders, hip girdle, and neck, along with an elevated ESR and rapid improvement with glucocorticoids. So it's associated and very similar to temporal arteritis, the treatment and the epidemiology. And sometimes with temporal arteritis, you can also see polymyalgia rheumatica. Here we are going to use glucocorticoids that are lower in dose than temporal arteritis, but you don't have to know that. You just have to know that the treatment for it is going to be low dose glucocorticoids. For polymyositis and dermatomyositis, it's going to present with actual proximal muscle weakness and elevated muscle enzymes such as creatine kinase. And you also have to know that all patients with dermatomyositis or polymyositis must be screened for occult malignancy. Popularly, it's what I see is ovarian cancer and also gastric cancer. You can also see it associated with lung or pancreatic cancer. For schizophrenia, you have to know that on imaging it shows symmetric enlargement of the cerebral ventricles. So they might bring up a vignette of a schizophrenic patient, and they're going to say, what are you going to find on imaging? And you're going to see symmetric enlargement of the cerebral ventricles. For neurologic syndromes, and these are very important, Sturge-Weber syndrome for step 1 is very important. It presents with a portwine stain in the trigeminal nerve distribution. So you're going to see redness on the baby's face, also seizures, and ipsilateral leptomeningeal angioma. And this is caused by a GNAC mutation. Another syndrome we have is Clover-Bucy syndrome, and this is caused by damage to the amygdala, and this is also primarily for the USMLE responsible for regulation of fear. And this condition classically presents with hyperphagia, hyperorality, hypersexuality, and hyperdocility. And this is associated with herpes infections, herpes simplex infections. Moving on to Brugada syndrome, and you have to know that this is an autosomal dominant syndrome. It's associated with SCN5A mutation, and you're going to get mutations in the sodium channels. And for that I made a mnemonic because there are other syndromes that are associated with mutations or in potassium channels. So the mnemonic for this is Bruno Mars, like the singer. So Bru is going to stand for Brugada, and the sodium is going to stand, the Na is going to stand for sodium. So Bruno Mars, Brugada, and sodium, Na. This has an increased prevalence in Asians, particularly in males, and for the USMLE they're going to say a pseudoride bundle branch block, ST segment elevations, and LEDs V1 or V2, and they're going to say what's the diagnosis, and you're going to pick Brugada syndrome. Or they might say this syndrome is associated with mutations in which channels. You're going to pick sodium channels. Or they might say what's the inheritance. You can pick autosomal dominant. Or they might say what's the treatment you're going to use. Primarily to prevent sudden cardiac death, you're going to use an ICD. And what is an ICD? This is an implantable cardiac or cardioverter defibrillator. Another very similar condition is the congenital long QT syndrome. And here you're going to get mutations in the potassium channels. So you have to remember that in the previous condition, which was Brugada syndrome, you get mutations in sodium channels. Here, you're going to get mutations in potassium channels. We have two syndromes. The first one is Romanoward syndrome, and this is an autosomal dominant syndrome, and it's purely cardiac. It has no other findings, such as no deafness. And the other one, which has deafness, is Jervell and Lange-Nielsen syndrome. This is an autosomal recessive syndrome, unlike Romanoward, which is dominant. And how can you remember that Romanoward is dominant? Because Romans are strong. So Romanoward is autosomal dominant. Jervell and Lange-Nielsen syndrome, this is autosomal recessive. And this presents with sensory neural deafness. And for the USMLE, you can suspect this if the patient presents with prolonged QT interval, syncope, and sensory neural deafness. And they're going to ask about the diagnosis, and you can pick Jervell and Lange-Nielsen syndrome. Or they might say mutations of which channels, and you can pick potassium channels. The other thing is colchicine. This treatment inhibits polymerization of beta-tubulin into microtubules, and it's used for classically three conditions for the USMLE. So you cannot enter the prometric center without knowing these. This is very important and basic information. So the first indication is gout and pseudogout. The second one is acute pericarditis, and the third one is familial Mediterranean fever. So you have to know these classic conditions: gout, pericarditis, and FMF. Also, another condition that I've seen is that colchicine is used in Behçet syndrome to prevent recurrence of painful oral and genital ulcers and thrombosis. So this syndrome happens in young males, Turkish or Middle Eastern descent, and they get painful oral and genital ulcers and also thromboses. So you can use colchicine for this as well. Its adverse effects include intractable diarrhea, rhabdomyolysis, so drug-induced rhabdomyolysis. Colchicine is a cause for that, and bone marrow suppression. Its contraindications include patients who are elderly or who have severe renal dysfunction. This is also very important, especially for step 2. So we said one of its indications is gout. So if a gout patient has severe renal dysfunction, what are we going to use? NSAIDs or colchicine. So colchicine, we cannot use this. We cannot use colchicine because the patient has severe renal dysfunction. And non-steroidal anti-inflammatory drugs, we can also not use this because the patient also has renal dysfunction. So what are we going to use for gout in this instance? We're going to use corticosteroids. Because here, for gout, we have 3 treatment modalities: NSAIDs, corticosteroids, and colchicine. If a gout patient has renal dysfunction, severe renal dysfunction, we cannot use neither of NSAIDs or colchicine, so we can use corticosteroids in this case scenario. Another condition that is rare is stiff person syndrome, and this is going to be an autoimmune condition attack against glutamic acid decarboxylase in the body. It's going to present with axial muscle rigidity and severe gait disturbances. So the classic feature of this is severe painful muscle spasms that lead to fall, precipitated by loud noises. So this is very classic for stiff person syndrome, but you have to keep in mind that Tullio phenomenon also presents similar like this. So Tullio phenomenon, which we are going to discuss how it can present in the next slide. So Tullio phenomenon is usually caused by perilymphatic fistula or sometimes Meniere disease. So a patient is going to hear a loud noise and they're going to get vertigo, and they can also fall to the ground. And this syndrome, which is stiff person syndrome, they can also hear a loud noise, then they get painful muscle spasms and they can fall to the ground. And we're going to differentiate between these two conditions in the next slide. And you also have to know that stiff person syndrome is more common in women and it's more common in patients with type 1 diabetes mellitus. In fact, patients with type 1 diabetes mellitus, and this is an autoimmune condition, sometimes you can see positive antibodies against glutamic acid decarboxylase as well. So, how can we differentiate between Tullio phenomenon and stiff person syndrome? So, if the vignette says the patient stiffens up and falls after a car horn, this is going to be stiff person syndrome. And if the vignette says that the patient gets dizzy, so vertigo, and sees the room spin after a car horn, this is going to be Tullio phenomenon. You have to also know that Tullio phenomenon is associated with which one specifically? Perilymphatic fistula or sometimes Menard disease, sometimes also with other diseases such as syphilis, but this is not important. You have to know these two primarily. Perilymphatic fistula, and this is very important, and then sometimes Menard disease.